Good morning, and welcome to the Cahill debate session. This is, I think, is a special part of our Spine Summit. In March of 2004, over 20 years ago, the section actually inaugurated the Cahill debate controversy sessions, and this was a recognition and tribute to Dave Cahill, who died tragically in a freak airplane accident in July of 2003. At the time, Dave was the chair of neurosurgery at the University of South Florida in Tampa, a very active participant in the spine section, as we called it. Those of you that remember Dave will acknowledge he was a brilliant surgeon and a brilliant teacher. He had a sharp wit, acerbic commentary on pretty much every speaker, every poster, everything we did at any meeting. And if you were actually standing next to him or sitting next to him at a meeting, you were either treated to or subjected to a running commentary on pretty much every presentation, complete with expletives and colorful adjectives. Dave was dogmatic, he was opinionated, but his opinions were based on experience and evidence. I presented this work of his at the March 2004 spine section meeting, kind of in his honor, and I think this reflected those qualities and was somewhat prophetic. This conclusion slide kind of reminds us that he never really shied away from any dogmatic opinions or platform and would stir up debate and controversy with his observation. So it's only in that spirit that and the memory of Dave that we perpetuate this with the Cahill debates, where topic experts seated before us duke it out over topics that don't have a clear consensus, except in their own minds, right, or evidence. And while entertainment is an element of these debates, the really underpinning motive is to help us really pursue the evidence and address the controversies that are sort of surrounded in these topics. Dave was a great friend. He was a colleague. He hailed from Danville, Virginia. He completed his undergrad and medical school at the University of Virginia and then neurosurgical training at the University of Maryland. He was recruited to Tampa, and then over the next 20 years, he actually took this sort of fledgling division of neurosurgery at USF and turned it into a department of neurosurgery with international stature. He and I were actually appointed chairs of our respective departments in 2000. So Dave and I sort of, in some ways, flew together, often commiserated on how to deal with challenges in our departments. But I really basked in his passion for and pursuit of spine surgery and trying to do it well or do it right. Dave showed us how to balance life. He had a wonderful family. He loved his wife, Sandy, and his kids. Right up there next to Sandy, though, was his love for flying and cool airplanes. We all heard the stories of these pretty cool planes. He learned to fly as a teen, never lost that love and passion. He loved to fly, but the desire he had was for the spine section, for us as spine surgeons to fly as well. For us to continually pursue the heights of superb spine surgery and science, and for our presentations and our work to be top flight. And it's in this spirit and memory of Dave that we begin our 23rd year of the Cahill debates. Our first debate topic this morning is a tough one. As difficult as it is for us to see a patient with a deformity who needs some major correction and figure out what the right angles and the end result's going to be and all the tools and techniques we're going to bring to bear, it is more intimidating to actually have that patient who shows up with a primary spine tumor that has sort of insidiously sort of eroded the spine and now impacted the spinal cord and not has just structural but neurologic implications as well. And oh my, that's the tough one. Because for many of these primary spine tumors, the the treatment involves not just the structure of the spine, but taking care of this problem without hurting the neurologic elements as well. And it seems like the epitome or the most challenging of these is this cotton-picking chordoma that really almost requires complete surgical removal with meticulous, delicate technique, although new technology may in fact have given us tools to treat this effectively without putting the patient through some sort of dramatic surgery, and it requires highly skilled surgical treatment as well. So it's an interesting challenge or concept. And I think here's an example. I'll set the stage with this 52-year-old man who presents with 6 months of progressive back pain, develops lower extremity weakness, comes in, is evaluated, exam, sure enough, modest weakness in the lower extremities, most proximal, some little decreased sensation, sort of patchy. He's complaining a little bit of a periodic incontinence. And then imaging, sure enough, reveals a lytic lesion in the spine, and the CT chest, abdomen, pelvis. There's no evidence of a metastatic or other disease. So this is a primary spine lesion. MR CT imaging, sure enough, here's this lytic lesion that has now replaced most of the vertebra and is encroaching on the canal as well. So the spinal cord is affected. The MR, more glowing evidence, right, of this vertebral replacement with structural implications, and then encroachment on the dura with some serious neurologic implications as well. So, needle biopsy, sure enough, spinal chordoma. And now, how are we going to deal with this? Well, Dr. Bilsky is going to try to convince us that separation surgery and adjunctive therapy are really the best contemporary solution. Dr. Gokaslan is going to convince us that no, highly skilled technical surgical on-block removal is actually the goal to cure or treatment. And of course, their backups, Dean Chou, will then sort of support Dr. Bilsky's perspective, Nick Dea will support Dr. Gokaslan's perspective, and then you'll vote. So gentlemen, start your engines.
Thank you for the opportunity to share this data. And I think if we take that case that Dr. Branch presented and put it into the NOMS framework, the patient's myelopathic with high-grade cord compression, grossly unstable, based on age can tolerate virtually any treatment, and they need emergency surgery. The tumor histology we know is chordoma, and Ziya has argued for over a decade, 20 years even, that you need to do an en-bloc resection for this tumor, but in the middle of the night, there's no way you're gonna get this patient to an en-bloc, and you can't do a wide margin resection. Your job as a neurosurgeon or a spine surgeon is to get this patient out of trouble, and your best option is to do separation surgery followed by high-dose radiation therapy to get durable local tumor control, and that's not based on conjecture, that's based on fact. En-bloc resection alone has poor local control rates and oftentimes prohibitive morbidity. High-dose radiation therapy has better durable local control rates and less morbidity than en-bloc resection. In many centers now, it's being used as definitive therapy. Where we have a target or where we have high-grade cord compression, we're now doing separation surgery followed by high-dose radiation therapy. It's not a new concept in primary spine tumors that adjuvant therapy defines the outcome rather than the resection of the tumor. And in fact, for giant cell tumors, which were previously en-bloc resected, we're now using definitive denosumab with excellent outcomes in these patients. And the new one added to this armamentarium primary spine tumors is chordoma. Surgical misconceptions about chordoma is that they're surgically curable with en-bloc resection alone. In point of fact, they rarely are due to anatomic constraints, prohibitive morbidity. Satellite and skip lesions account for early marginal recurrence, and fully 30% of these will metastasize. The second misconception is that chordomas are resistant to radiation. In point of fact, they are resistant to low-dose radiation, but they are exquisitely radiosensitive to high-dose radiation with a biologic equivalent dose greater than 70 gray. And that can be given, for instance, in 70 gray and 2 gray per fraction, or 24 gray single fraction gives you a BED of 150 gray, but require advanced radiation techniques to deliver these doses within the constraints of normal tissue tolerance. And this can be done equally well with proton beam, carbon ion, or photon-based SBRT. And all of these radiation techniques provide a local recurrence-free survival benefit versus en-bloc resection whether used as neoadjuvant, post-op adjuvant, or even now definitive radiation with no surgery. En-bloc sacrectomy is actually a bad operation for chordoma. Both the MD Anderson and Memorial series show 5-year local control rates of 60% with major complication rates of 75%, including loss of bowel and bladder for high sacrectomy. The Sacral Tumor Society looked at 193 patients undergoing en-bloc surgery with or without low-dose radiation therapy. They had 10-year data. The 10-year local control rate with en-bloc alone is 27% with a 3% risk of secondary malignancy. Definitive radiation offers better local control than en-bloc resection. In series looking at proton beam and carbon ion, the 5-year local control rates are about 80%. Complication rates fall to 30%. The vast majority of patients will maintain bowel and bladder function. Insufficiency fractures occur in 22%, but are now readily treated with clinical nerve ablations. Here's our series most recently from Memorial Sacral Chordoma, Pat Boland's series of 119 patients. Patients receiving high-dose radiation therapy only did as well, if not better, than en-bloc only or en-bloc plus high-dose radiation with 5-year local control rates of 88%, durable out to 10 years. Complication rates are 10-fold lower. Most of the data on en-bloc for mobile spine tumors comes from the AO Spine Knowledge Forum, first authored by Ziya Gokaslan. It generated this beautiful curve where EA, or Anakin-appropriate en-bloc marginal or wide resection, did significantly better than Anakin inappropriate en-bloc or curettage intralesional. And this has been used to justify en-bloc resection for the past 10 years. Radiation in this series was a negative prognostic variable. And of course, with all studies looked at through a modern lens, there are significant shortcomings in this study, the biggest of which is the short follow-up underestimates recurrence. Despite the fact that this was a 24-year retrospective, the median follow-up was 2.6 years. We have no idea what happened to most of these patients at the 5-year mark. Adjuvant radiation was all low-dose radiation, as they didn't have availability of modern ablative protons, carbon ions, or SBRT, and there's no discussion of morbidity, which often defines the outcomes in this patient population. Here, in a case report by Larry Rhines, 2005, from MD Anderson, of a C2 to 4 chordoma that underwent a transmandibular osteotomy, occipito-cervicothoracic fusion. Complications were prolonged ventilation and pharyngeal dehiscence. And at the time they said, while en-bloc resection is feasible, should we really do it in any of these patients? And they reconfirmed that in a paper from Molina in 2014. More recently, they've gone to image guidance and 3D modeling printing to try to get a better resection on these patients. This is a patient with a high thoracic chordoma undergoing an anterior trapdoor and posterior cervicothoracic fixation. But it doesn't mitigate the complications in this patient population. The patient had new onset aflutter, lost vision in the left eye, had a pleural effusion from pulmonary edema, anterior chest wall infection and septicemia, neuropathic pain, and then, as expected, at a year, there was a recurrence of tumor. Since the AO paper came out, there are 10 papers that have demonstrated an RT benefit compared to en-bloc alone. One of the most compelling papers actually comes from Johns Hopkins, Ziya Gokaslan's experience with 101 patients in the mobile spine and sacrum. The vast majority underwent an Anakin-appropriate operation. Radiation was given in about 40% of patients, of which 22% received it as neoadjuvant therapy. Recurrences were about 25% at 4 years, and complications from en-bloc, as expected, were about 65%. In multivariate analysis, EA versus EI had no impact on local recurrence-free survival, but what did have an impact was neoadjuvant radiotherapy, confirmed an 11 times lower risk for local recurrence. This was also seen in the MGH series of 76 patients in the sacral mobile spine with a median follow-up of 9 years. Patients undergoing en-bloc plus high-dose radiation therapy did significantly better than those receiving low-dose radiation therapy with 5-year local recurrence-free intervals of 93%. And again, it didn't matter whether you got an Anakin-appropriate versus inappropriate operation if you got high-dose radiation therapy. So the question becomes, in the era of high-dose radiation therapy, how important is en-bloc resection? And the answer is, it's not very important, if at all. Here's a series from Rizzoli, the major cancer institute in Italy, looking at chordoma of the mobile spine. There were 2 cohorts, one where the newly diagnosed patients got an en-bloc resection, plus minus protons or carbon ions. At first recurrence, patients got curettage intralesional resection, followed by carbon ions or proton beam. There's no difference in local recurrence or overall survival. Here's our series from Memorial, photon-based SBRT, 35 patients in mobile spine and sacrum, looking at single fraction radiation, typically 24 gray single fraction. In the mobile spine, if we had a definitive target for radiation, we simply went to radiation therapy. If the patient had high-grade core compression, with or without myelopathy, we went to an EI surgery, either curettage gross total or eventually we transitioned to separation surgery. The bottom line is the patient got 24 gray single fraction, and the 5-year local control rate was 90%. So what we did essentially was we took that AO curve, that Anakin inappropriate, and with the addition of high-dose radiation therapy, we moved it below the Anakin inappropriate. This was seen in the photon-based data from MD Anderson at 24 gray single fraction using a definitive radiation. They also showed 5-year local control rates of 90%. And photon-based and the UPMC similarly showed with a little lower dose strategy using stereotactic radiosurgery as definitive post-op adjuvant 2-year local control rates of 80%. We now have longer-term data on our single fraction patients at Memorial, and you can see that the 10-year follow-up at 24 gray single fraction, we have 88% local tumor control.
Well, thank you so much for including me in the debate here. I think Mark needs another half an hour to be able to convince the audience here that radiation therapy really is a treatment for chordomas. There's no question in Bloc resection is the best treatment for primary spinal chordomas. Let's look at the data. Here is a case that we're discussing, a thoracic spinal chordoma, which is a favorable location. You can sacrifice the nerve roots, you can manipulate the spinal cord, you can resect the tumor without entering it. Here is a tumor that's extending into the epidural space on the right side. And here are the two different ways you can do an en bloc resection. Either you can do wide resection where there's healthy tissue around the tumor, or you can do a marginal resection where the tumor capsule is kept intact and you didn't enter the tumor. Here's what we do in the sacrum, typically a en bloc wide resection where there's healthy tissue around the tumor. Here's what we do typically in the mobile spine when there is disease in the epidural space where the tumor can be removed completely without entering the tumor capsule. I think this issue had been settled. This is really the evidentiary table that we had in Milan in June of 2025. All the experts from around the world came in, including radiation oncologists and medical oncologists. We extensively debated what is the best treatment for mobile spinal chordomas. You can see at the bottom, when feasible, en bloc resection with negative margins is the recommended treatment for primary spinal chordomas. And here it is, the Statuides data from Italy showing that in every case, whether it be the recurrence or the survival, en bloc resection is better than intralesional resection. This is our data from AF Spine Tumor Knowledge Forum showing that en bloc resection is better with negative margins as far as survival and the recurrence is concerned. Here is the data from Johns Hopkins, and my esteemed colleagues actually used this to make the case that the radiation therapy is a better treatment. Here are the results from over 100 patients with 20-year follow-up. Many of them are mobile spine tumor cases. You can see overall recurrence rate is 75% over that period of time. But more importantly, 9 out of 10 times one can do an en bloc resection with negative margins. So making the argument that you cannot do an en bloc resection is not a valid one because you can accomplish that and the complications are listed there. And here are the results on the statistical analysis. You can see anything appropriate resection is statistically significantly better than an intralesional tumor removal. And finally, if you look at the bottom box there, adjuvant radiation therapy didn't really have any value in treating primary spinal chordomas. And here is the data from MGH using proton beam radiation therapy as an adjuvant treatment. Even in that case, if you look at the results, the en bloc resection is better than intralesional resection in conjunction with proton beam radiation treatment. And this is what happens when you get a recurrence. It's a terrible thing. Survival is very poor. Local recurrence, as you can see in this paper, was associated with almost 23-fold increased risk for metastases, 32-fold increased risk of tumor-related death. So when you get a recurrence, it really a death sentence in the setting of a chordoma. And here's the case again in question. Here is the WBB diagram that is superimposed in that, and we're going to walk this case. This is another case of mine, quite similar. I'll tell you how this can be done. You can do it all posteriorly, or you can stage it if you like. Here's the posterior approach, laminectomy is above and below, removal of the posterior elements. Typically, you can do that with the osteotomes on either side. Here are the posterior elements removed, and here is the plane that you're going to use to establish the the dissection plane between the vasculature and the vertebral aspect, ventral aspect of the vertebral body. And here is the malleable retractor actually is placed under the spinal column behind the great vessel. Here how it looks like in the operating room. The nerves are sacrificed on both sides, which is inconsequential in thoracic cases. And here is the resection of the tumor. Here's a specimen. At the left bottom corner is the specimen from that patient that I've shown. And you can see another patient at the top, another specimen, which is quite similar to this patient where the transverse process, articulating processes, and a part of the lamina was also removed in an Bloc fashion. And here is a defect that's left behind that needs to be reconstructed using typically a distractible cage. And then the final construct looks like something like this with a couple of levels of screw implantation above and below and fixation. And this patient of mine is now 14 years out after a resection of this tumor with negative margins, with no additional treatment, and doing great with no evidence of cancer to be found anywhere. So in summary, en bloc resection is the best treatment for primary spinal chordomas. Our consensus meeting in Milan, a multidisciplinary meeting, including Dr. Bilsky here, including radiation oncologist from Joshua, came up with a consensus statement, which will be published in JAMA, the oncology, within the next couple of months. That is a consensus statement from a multidisciplinary team of experts. The local recurrence, as I've shown you, is associated with terrible outcome. It literally is a death sentence for a patient with chordoma to get a local recurrence. Of course, we need to factor in the patient preferences and the oncological objectives when we are dealing with these tumors. The radiation therapy definitely has a role if you cannot resect the tumor, or if you attempt to resect the tumor and there is some of the tumor left behind despite your best efforts. But in summary, en bloc resection is the best way to treat these tumors. Thank you.
All right. So the gauntlet's been laid down. Now we're going to have the sort of the backup, right? The backup players. Dean, convince us that what he actually said makes more sense than what Ziya just said.
Yeah, so I'm going to make the argument that the en bloc is just too morbid. These are my disclosures. So you heard the data and you saw the argument, you saw the papers, and really en bloc surgery has a complication rate of over 70%, right? So Nick and Ziya are going in their battle and they're going with all this blood and they're having all this fun doing these cases, but really these are complex surgeries with very high complication rates. Whereas Mark and I are going in doing separation surgery, low complications, low morbidity. And the reality of these en bloc surgeries is that there's almost many times you will get some spillage, right? Even in the best of hands, and Nick and Ziya are great technical surgeons, but even in the best of hands, there may be some spillage. In addition, there is microscopic disease that's in the muscle. Sacral chordoma is a great example. Patients sit down, there might be some microscopic disease, et cetera, et cetera. You can't see that on the MRI, and you can't see that intraoperatively. So there's going to be some spillage. But if you go in, have a happy patient, do what you got to do, and get separation, take the pressure off the spinal cord. And the patient Dr. Branch showed, basically you need to have separation to prevent paralysis. And ultimately, what Dr. Bilsky showed you is the radiation that controls the disease, not our knives, right? It is the radiation. And doing the radiation, we know that if you deliver a high enough dose of radiation to any tissue, you will eventually kill it, right? So at the end of the day, you know, Nick and Ziya are doing these technically great procedures and very cool, great videos, but they're morbid, they're bloody, and the patient is very unhappy. Whereas Mark and I are doing these great separation surgeries, the patients are super happy, they do great, and we have great control of the disease.
Many people in this room want to believe that separation surgery is the way to go. And I cannot fault you for this. It would make our lives way easier. And then you have establishment in the field, and they're telling you, you know what, you can just do a separation surgery on a chordoma. That's great. So everyone's happy to hear that. Essentially, what they're telling you is that you can treat a chordoma just like a lung cancer metastasis. Does this make sense to you guys? And then they will present you a bunch of series and a bunch of data, but let's recenter on the question today. This is a separation surgery for virgin mobile spine chordoma. If we fish out all of those patients from those studies, this is what we see. Small number of patients, short follow-up, small number of patients. We even hear that chordomas are exquisitely radiosensitive. Well, I'm not sure what's the radiobiology of chordomas in New York, but I can tell you that Canadian chordoma are not radiosensitive. Now, we're looking at unresectable tumor. Again, selection bias, a lot of small series, and it's very difficult to interpret the data from these series. Again, short follow-up, what can you say about this? So we also heard from Dean that there's prohibitive risk for those surgery. Well, we actually looked at this, and it's not prohibitive risk at all. When we looked at all our data, the adverse event is roughly 40%, which is not small, I agree, but it's actually way smaller than for the metastatic spine disease, and all of us will operate on a MET any day. Makes sense. The younger patient, healthier, better performance status. So when I have a case like it's presenting to us today, what I do is that I take it out properly, I reconstruct properly, and actually I'm happy with my day, and I even made it in time to school to pick my son after school. Now, Ziya also talked about this, but we all met together in Milan. And Ziya was there, I was there, Mark was there. We debated. And as you can see them today, you can only imagine that the debate were quite muscular. But at the end of the day, we had a consensus agreement that when feasible, an R0 on block resection is the way to go for mobile spine chordoma. So I'm sorry if you wanted to hear that separation surgery is the way to go. I don't think we should have 80 patients from 10 studies not designed to answer this question change 2 decades of experience in en bloc resection and basic MSK oncology principle. This should not be treated the same as this. These are different diseases. Thank you.
All right, some pretty compelling evidence, right? I mean, this is actually, again, thank you for adding some humor, but really delivering some serious evidence on both sides. Who actually convinced you? Ziya, thank you for showing us how to do on block resection well. Mark, thank you for showing us that there are alternatives to actually taking somebody apart and putting them back together. Thank you guys for a great debate and for doing what you do.